All right, everyone, I think we'll go ahead and get started. Welcome to the Deepening the Skill Set for Return to Work Psychosocial Intervention Made Practical webinar. This is the 8th webinar in our Return to Work Stay at Work series, and we're glad you're here today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar was made possible through the support of the Direct Access Program through the BC government. As I mentioned, my name is Tanya, and I'll be moderating the session. And we also have online Lisa Mighton, who is CIRPD's education coordinator, and she'll be handling the question and answer session today. And our presenter is Dr. Matt Graham. Dr. Graham is a registered psychologist and team psychologist at Orion Health. He's been with Orion Health in Rehabilitation and Assessment Center since March of 2008. After graduation from UBC's Counseling Psychology PhD program, Matt continued his involvement in research by initiating and helping to conceptualize a joint research project with the University of Calgary. Matt has also developed and implemented a multicultural competency development program for the Orion Health Surrey Clinic. And I'm just now looking at his slide and realizing his title at Orion Health has actually changed. He's the Senior Manager of Clinical Practice and team psychologist now. So I will go ahead and hand it over to Matt. Thank you very much.
Thanks very much, Tanya. Definitely want to start out by saying it's my pleasure to spend the next 45 minutes trying to, I guess, offer what I've learned along the way of different strategies to encourage folks and motivate folks that have chronic pain to, I guess, engage in difficult challenges. Also, as we start, I'm just realizing, looking at the picture, that I missed my mustache and I can't wait till November to grow it back again, much to the chagrin of family and colleagues. I wrote goals, but I have several goals that I would like to try to accomplish in this talk. One is that I'd like you to have an experience. It just came out of a week of training, and actually the real push was we learn better when we are at least somewhat uncomfortable. Not tremendously uncomfortable, but not also really, without any discomfort. So before I even go further, what I want to do is encourage you to put your feet on the ground, and we're going to have an experience. I want you to, again, this is a challenge by choice, but I'd like you to breathe in through your nose, deep into the stomach, slowly out through your mouth. Just be aware of transitioning from doing your work or being somewhere else to being present here with this talk. So continue this breathing. I want you just to see if you can think about the thoughts that you're bringing with you into this talk. What are your expectations? Now that it started in a unique way, now what are your expectations? Again, this is tricky, right? So don't expect that you're going to get it off the bat, but be aware of how your expectations are impacting how you feel. And so I'll get us to stop that at this point. But my goal is, as we go through and looking at some of these basic skills that we can offer, that we get a chance to experience them today. So the next bullet, definitely want to give you some skills, but obviously not a full toolkit. Want to try to validate your existing skills and maybe give you a bit more of a relational approach that might get better results. On the advertisement, there was a suggestion that motivational interviewing would be something that we would look at, and definitely want to introduce you to that, and also some techniques around motivational interviewing. I find that people have also given me good feedback that having ways to describe the transition from acute to chronic pain and normalize that transition for clients. Sorry, I'm getting some significant feedback. Tanya,
Yep.
Can you hear that?
I hear that as well. Just give me 1 second.
Okay.
I'll see if I can find... Okay, I got it.
Okay, super. So want to spend some time offering you some ways to understand the transition from acute to chronic pain and some ideas on how to help normalize it and describe it for clients who are going through it, again, in service of the return to work process. So The last one is that I'm hoping that by the end of this, we'll all be able to better identify and help support the natural client resistance, not support resistance per se, but to be aware that resistance to the circumstances and to the rehabilitation process, if we can find ways to name it and talk about it, can actually decrease resistance. So obviously I got a lot of goals, so I better get to work. Let's orient ourselves, even with what pain is. And we won't spend too long on this. If you've done any reading in the literature on pain, you've seen this definition before. Pain being an unpleasant sensory and emotional experience associated with actual potential tissue damage or described in terms of such damage. I think why it's important to start is that right off the bat, if we see the emotional response coming out to pain, and it looks like this is going to be something that we could be helpful with, good to start on that right away, as opposed to waiting 3 to 6 months when the quote-unquote formal definition of chronic pain kicks in. So from that definition to Lorimer Moseley calling brain as a pain output, that has been a very useful distinction for clients to understand that my brain will sometimes produce pain even though the threat of tissue damage isn't there. I'm going to speak more to that in a minute. But you'll see this theme throughout the entire talk. In fact, the psychological dimensions of pain can arise quite early and be detectable and treatable, and something that's important for all of us to know about and have some strategies to point out and to work on. So there is a typical distinction when talking about pain, and I think I've already made this. One is that is acute pain, which is generally accepted as being due to tissue damage. And often, this is not often, always, this is where we get the medical response. Chronic pain, generally accepted as lasting longer than it should have in order for the person to, quote unquote, get better. And at this point, and if you can follow that curve, often that pain is more associated with the nervous system, and I would argue, kind of in part, at least, the emotional response, the pain alarm system, and less about the tissue damage. So what is more chronic? We have the same person at the same age with severe knee osteoarthritis, waiting for total knee replacement, continuing to work and golf, albeit at a more gentle levels of each, versus someone with a lumbar strain a month ago at work, has degenerative disc disease on his scans, no impingement, and into a place of bad sleep, unable to work, financial stress, and mood changes. And this idea of being aware of our response to the pain, being aware of contextual factors, and having language to speak to the difference between hurt versus harm or hurt versus damage is important right off the bat, especially even early on when we see folks that haven't reached the 6-month cutoff for chronic pain. And I wanted to speak to you about having metaphors, but it doesn't seem like it fits quite now, so I will come back to that. All right. So when one moves into this place of having to return to life, and they're not pain-free, being aware of expectations is really important. And often when we're in the acute phase of injury, expectations are that the physician, or some medical professional is going to find the cure, find the response, and help us fix it, right? Chronic expectations, often people don't necessarily have expectations, and they hold on to the fact that, I would like to eventually get to being pain-free, or the expectations are dashed because the medical system has let them down. And what I found to be very helpful is to try to get people to hold a both-and approach, where we hold on to the expectations of improvement, of getting better, of becoming more functional, at the same time of expecting that we need to learn how to work with pain in our daily life and that we can improve if we're willing to work with pain. If the transition doesn't happen very well and we go from waiting for someone to help us, and then those people can't help us, that pattern is often the very important one to address in order to encourage sufferers with pain to begin to take more ownership, more skill set, more responsibility for the process. And early on, after injury, these are some of the warning signs that we see that sort of give a signal that difficulty may happen with dealing with the emotional or the psychological side of pain in the future. So there is a line of literature that has looked more closely on the psychosocial factors. In the reference list at the end of this talk, there's a very good review done in 2011, and I don't have it handy, but you'll see, I think it's Nicholas. I've got it cited later on, looking at early warnings of pain and disability in the process of job loss. And again, it comes back to beliefs, and having awareness of, even though pain is now being more moderated by the nervous system versus due to tissue damage, having beliefs that pain is harmful or disabling plays a significant role on long-term outcomes. And actually, I'm just going to go back to this slide. For us, we need to know how to articulate to clients and get them to understand the difference between pain that hurts versus pain that does damage. And so one metaphor that we found in our clinic that works quite well is that idea of a house alarm, right? An alarm that your house has been broken into, something's been stolen. It's very scary. It's a violating experience, and so spending all the money you can in order to get the most sophisticated alarm, and it gets so sensitive that a cat walks in front of the house and the alarm goes off. And someone drives by and the alarm goes off. It's like the car alarms even in the parking lot. And often that's what can happen, where our pain alarm system gets so sensitized that it goes off unnecessarily, even though there isn't a damage issue or sort of a threat of harm issue. So the encouragement in me sort of coming back to this is, ask yourself the question, do you have the metaphors to help clients understand the difference between acute versus chronic, and translate it to their own experience? So fear and avoidance of activity or movement, that idea of getting into the pattern of waiting and not learning how to work with the pain or do activity with the pain, that's a pattern that sort of signals that difficulties are coming in the future. Tendency to low mood, and expectation that passive treatment rather than a belief that active participation will help. So let's move into experience number 2. Well, it says number 1, but we've already had one. And for many of you, this might be a review, but again, the issue is, as we're helping people to transition from acute to chronic pain and learning how to deal with it, we need a well-developed skill set to deal with stress and the emotional side of things and the cognitive side of things. So we're going to spend a minute here, and I find it useful to review in my own practice to review diaphragmatic breathing for myself. So the best way to teach this, first of all, is to have the discussion, with our clients. Do you find that pain, does it make sense that pain creates a stress response? And if that doesn't make sense, ask. I find 9 times out of 10, if you say, well, when you're the most stressed, you telling me about all these difficulties that you're going through, how does that impact your pain? And not everyone, but most folks will say, well, my pain goes up. And that's usually a nice bridge or a way of getting to talk about how important it is to develop a regular practice of self-management or self-soothing techniques. So let's do this now. One hand on the chest, other hand on the stomach, usually right on the chest, left on the stomach. And breathe in slowly through the nose, deep into your stomach. Stomach expands as if there's a balloon in there. And then breathe out very slowly through the mouth. remembering to focus on the fact that the out breath is longer than the in breath. And the other thing too, as you continue, I want you all to continue to do this while I just give you a bit more information. A lot of times, this is as far as we get. And we teach these to our folks, and then we're not too sure about why they won't do them, and we move on. And often what clients tell me why they won't continue to do it is because their mind wanders and goes all over the place, or it's too difficult to focus on the breath and not think about pain. So we want to train our people as we teach them these skills to realize that if they try not to think about pain, it's a trap called cognitive fusion. The more you try not to think about pink elephants, the more you will. So really choosing to focus on the breath or focus on something while you're doing this can make a difference. So if you've stopped, still want you to do one more deep breath. Breathe out. And just summarize the fact that we are learning skills to help our clients transition from acute to chronic pain, and then find ways to nuance these skills that they can be translated into the context of work so that it can support the return to work process. Okay, so a bit of a context, right? What are we talking about? Acute versus chronic pain. What are the challenges as far as dealing with pain that's produced by the nervous system or maintained by the nervous system? Important for us to be able to talk about hurt versus harm, and to have clear ways of inviting people into relaxation strategies. Motivational interviewing is something very important to know about, and I'm going to promote this book right now because I found it to be so helpful. It's called Motivational Interviewing in Healthcare, Helping Patients Change Behavior. And it's just an elegant book that teaches a lot of key skills that can make us, empower us to do our work even that much more effectively. Motivational interviewing has been defined as an empirically supported, client-centered, directive counseling approach, basically helping to improve motivation and decrease barriers to change. And I like the fact that it's client-centered and directive because it allows for us to be compassionate, but also guides where it is that we help our clients pay attention to, right? And you'll see where the directive piece comes up in a minute. Guiding principles for motivational interviewing, learning to resist the writing reflex, and that's for us to do. And I'm going to talk about that in a minute. And you saw that I write there, say no to persuasion. And that's not as easy to do as it first seems. U is to understand the patient motivations. Great article in the references in this talk on how important it is to understand client expectations for return to work and how infrequently we do a systematic job of getting those on the table. Listening to the client and empowering the client. I'll say why it's important that we talk about directive because it focuses us to listen to any statements that our clients are making about what they want in relationship to change, and directive in the sense that we're looking at what either statements for change or barriers for motivation. So before in this book, before they get into teaching much more about motivational interviewing, they get us to do a self-assessment of our own communication styles. Because as we do our work, this is relational work, and we all have styles. And their argument is that we typically have a default style. So let's go through these. First one is a following style. Basically it's our goal to listen to how the other person's doing, put our own stuff aside, and give them our full attention. And my hunch is that most of us do that from time to time as we try to understand what's going on for our clients. Directing or taking charge type style often implies uneven power relationship. And I know for many of us there is, with our clients we do have an uneven power relationship. And I wrote clinician process there. I'm not so happy about that because I think a lot of times it's about the process of the system that we work within. Not always, but often. The third style would be a guiding style, helping facilitate a person, get to where it is that they want to go. I can help you solve this problem for yourself. So the argument in the book is that it's important for us to know our own communication style well, and also to challenge ourselves to see, are we stuck in one or the other predominantly, or do we have a way of knowing when to move between these communication styles? So directing, when I look at this, I think, oh, directing's bad. I don't want to be a director. But yet there are some important times in these relationships that if we don't sort of take that space, then our clients will, potentially stay in a pattern of avoidance, right? Avoidance of pain, avoidance of moving forward, and sometimes direction is definitely needed. But direction all the time, it'll reduce the chance of us making deeper connections and helping eventually get to the place where we're following the client process, which is, ideally, which is what our goals are about anyway as we do our work. That's enough to say on that. Within communication styles, there are also specific communication skills. So do we have the capacity to ask good questions to draw out change talk, right? Or to get at client expectations? Do we remember the listening skills that we developed in school, or have we sort of fallen off of doing the disciplined work of actively listening? And the benefit of active listening is that the other person might be wrong, but if they feel understood, there's going to be less resistance to the process. It'll slow the process down, and it'll decrease the chance for communication errors. And you're going to be working with a person that has better feelings towards you and the process. And it's very respectful to have informing as part of your communication skills. Giving our clients as much information as we can about the process or the goals, and about our limitations. So out of that, I think it is useful to think about the skill of empathy. Empathy is not sympathy. Empathy is finding a way to convey understanding and caring while still remaining as emotionally detached as we can. I don't think, that's only my perspective, and this could be just my personality. I don't think that if we bring compassion to our work that we can be completely detached, but I think it's important for us to do regular self-evaluation so that the emotional impact of our work doesn't cloud our judgment and our way of being with our clients. If you are going to take sort of an empathic or relational stance in your work, it can be really helpful for clients to even talk about the ground rules. Here's how I gave an example. Here's how I try to balance communication and doing my work, right? Or here's how here's how it makes sense from my perspective for us to do communication. And then you can elicit from the client, what kind of communication will work best for you? How are we going to navigate when we come up against difficulties? Normalizing, hey, this is a challenging process that we're going to go through. If we spend some time doing ground rules, that could be quite helpful. So I've put the different skills. I could do a whole course just on interrupting. Sometimes that can be quite helpful. And if you have a predominantly following style, interrupting is even that much more difficult. So maybe just Google interrupting if you're not sure how to do it. But summarizing, paraphrasing, clarifying, starting off with, so what I'm hearing you say is, and say what you heard, and then have I got that right? Actually, I'm going to go back to interrupting. A great way to interrupt is if you use put your hand up. You could say something along the lines of, like, I'm sorry, I just need to interrupt you because I want to make sure that I'm hearing what you're saying. And if you throw in that last piece, even if the person's offended, 9 times out of 10, I find anyway, that they'll relax and give you a chance to say, hey, so what I'm hearing you say is, and have I got that right? The other piece could be for you to use your own emotional awareness to normalize what the client's going through. If I'm in your shoes, I might be feeling freaked out or angry or lost. Does that fit? But not staying too long there before we get into, can we discuss where we want to go from here? Okay, so it feels like a quick transition. So motivational interviewing, being aware of the rules, and one of them is, understanding the client through empathy. We're going to get to more of them. But what I would like to do now is have us look at another grounding exercise. Diaphragmatic breathing, not too bad to teach to our clients. And that whole idea of having skills to deal with the stress response of pain, right, or the stress response of stress, not too bad. This next one is mindful breathing, and I don't want to be disrespectful to the depth of mindfulness by offering it here without much explanation. But I do want to talk about how this idea of resistance, and my hunch is, and I could be wrong, but my hunch is that many of us have encountered resistance in our clients, resistance to the process, feeling mandated, feeling forced. I also want to name the fact that people who have a daily experience of pain likely have feelings of resistance toward that unwanted experience, myself included. Right? I have a sort of an infrequent but a chronic pain issue, and when it comes up, I don't like it. I don't want it, and that unchecked resistance can lead to increased suffering, right? And our beliefs about whether something's unwanted, right, or our judgments on it impact that resistance. So, feet back on the floor now. And let's go back into diaphragmatic breathing. My understanding of mindfulness, as we do this, my understanding of mindfulness is that the goal is to practice paying attention to your experience in the here and now, moment by moment, non-judgmentally. So, get into this place of breathing. Just be aware of even what's going on around you in the room right now. Your experience, at least in part, is related to this talk, I'm sure. You may also have body symptoms that you're experiencing. Again, practicing this idea of being aware now of your thoughts or your evaluations. And the challenge would be, can you look at those evaluations as not necessarily being, the experience rather, not being good or bad, it just simply is right now. And this is tricky. It's important to develop the ability to identify how resistance impacts our experience, and how our evaluation of whether something is good or bad, wanted or unwanted, can impact our experience. So hopefully you're either observing me breathe, or you're all breathing and kind of thinking through these ideas. They're complex ideas. So to boil it down, even awareness and the ability to talk about resistance can be quite helpful. Okay, so that was a little mindfulness break. Let's get back on to other key accessible concepts for motivational interviewing. And in their book, Milner, they're not the only ones who've talked about this, but they talk about the paradoxical effect of persuasion. So I've kind of mentioned this before. Most of our goals, I think, in this helping profession are to heal, to promote well-being, to prevent harm, and of course to facilitate the return to work process and help people return to productive functioning, right? And I think that's a very noble goal. It's not an easy process to go through. And I'll self-reference on this one. I notice for me at times I develop a sense of urgency to help clients correct their course. I've only got them for how long, and they're not buying in, and they really need to. This is my self-talk. They really need to know that don't waste your time because we got to get going. And so subtly or even overtly, I'll find that I'll end up trying to persuade folks. Sometimes I'm working harder than my clients. And I need to be reminded regularly that the natural human tendency is to resist persuasion, even if it's true that you need to make a change. And think about how you respond to advice in your own life. When people give you advice or tell you what to do, typically you've thought through that stuff already. So it's common to experience ambivalence on the cusp of making a change. And so if we argue one side, the writing response is for clients to reinforce the other. And that can happen on a semi-conscious or an unconscious level, right? So the writing reflex, I push down, they try to write the ambivalence by pushing back. So our goal, if you look halfway down the page there, our goal is to develop a style where we evoke arguments for change from the patient or the client. Important for us to listen to and attend to any kind of change talk. So I'll give you an example. Working with folks in pain who have really high levels of opioids on board, and trying to help them come off of or reduce their opioid use. What I found is if I ask them just what's it like for you to be on these medications, and often right off the bat, before we're actually talking about the change process, we'll be, I don't think they're working. Sometimes they might say, well, they just take the edge off, or I don't like the side effects, or I wish I could change. And then we get into talking about, days later, okay, here's the process of change, and resistance will come up. Well, what are you doing to me? Like, you're taking away the one thing that works, and there'll be anxiety or concern about that. But having heard the change talk before, gently come back to what I heard you say at the beginning was that, this is what you wanted to have happen. Or if you could get help, that's what you wanted to have happen. And very rarely when I am able to, gently feedback, hey, this is what I heard you say you wanted to have happen, do I get resistance? I may not get full buy-in. Oh yeah, that's right, good, let's do that. That's a bit unrealistic. But it typically, if it's true that's what the client wants, then that often can provide significant motivation. I'm going to speak to this in a minute, but asking about any exceptions that you're getting to global statements. Right? I can't do anything, for example. So it's a great tool or technique to be able to say, are there any exceptions to that? Usually that I find that will stop a patient or client in his or her tracks, and we may not even have to have that discussion, but being aware that, because a lot of times our clients don't hear that that's the kind of language that they're using. So I'm not going to make you breathe on this one, but I'm popping in a grounding skill 3. And this has to do with flare-up planning on the job. If you think about the one thread that we've been pulling on through this talk, hopefully with practice, 3 times a day minimum for a couple minutes, using some kind of relaxation technique will eventually lead people to be able to bring on a relaxation response a lot faster. So, we're keeping in mind these new techniques, this process of return to work. There's still pain, there's still resistance or distress. So encouraging our folks to step aside and breathe just for 20 seconds, really quickly. And then get into doing that, self-evaluation. What's really happening for me right now? Have I done something dangerous? What is this pain about? Is it damage, right? Or is this a natural, is this hurt? There's a good technique for folks who are, struggle with anxiety and quite reactive. If they can practice coming up with at least 3 alternative explanations before they decide how to respond from that point. And I find that works well with how we respond to pain. And I've even done this with folks that I'm helping monitor on a graduated return to work. Can you take 2 minutes outside, 2 minutes, and you don't even have to leave the situation. Come up with alternative explanations for why you're responding this way, why your pain might be, increasing. And again, if you get into that relaxation and slow that whole process down, at times people can then identify, oh, okay, this is coming from stress, or you know what, I just hate this whole process. I'm resisting it right now. And then move into a plan. Do I need to do more breathing? Have I got off of using my tools that I learned, that I wanted to bring with me to this task? You can read number 3 as far as plan. So come back to transition. I think I've spoken to this a fair bit. This idea of moving from the acute phase of injury to the chronic phase, or having to move forward, be active, improve daily living, get back to work with some kind of pain response. And often the thinking is, if you go back to that initial graph, that this chronic pain includes the emotional dimensions to it. It's real pain, right? But the nervous system is producing high levels of pain that, through the different techniques we've been talking about, can be dealt with. At least the stress or the psychological dimensions of pain can be dealt with. So having the skills to deal with expectations, right? Being able to, I'm going to skip the second one, being able to articulate, and this is an important piece, being able to articulate this transition that I'm going through, having to, find a way to work with pain, has impacted me at the level of my identity, and impacted my ability to complete roles in life that have brought me satisfaction or meaning. So at the core, some of these motivational interviewing ideas, those are skills, they're sort of getting at the day-to-day, but underneath all this, at the core of this transition, at least in my opinion, is that there has been a threat, or short or even a long-term threat, to a sense of oneself and the roles that our clients can fulfill. So why am I telling you this? Well, if we can give language to this and normalize it, typically it decreases a significant amount of distress that impacts, motivation, and impacts even the experience of pain sometimes. So what I've found over the years, to give this to clients, to say, something's happened to you, and what I hear other clients say is that it's typically impacted who they knew themselves to be. And 99 times out of 100, I get, yeah, that's exactly right. You knew yourself how to be strong, vibrant, doing all these things, never a care in the world. And now, through even a violent process, or, a slow degenerative process, here you are with the task of having to move forward with pain. You're living with significant uncertainty. And what I hear you telling me is that you're not even sure if you can do it. And on top of that often is, and I can't be the person that I used to be for the people who are most important in my life. And it doesn't mean that if we get into talking about that's how it's going to be forever. But if we can talk about the experience of going through transitioning from, I trusted my doctor and now they let me down because they didn't fix me, right, or didn't give me the solution. Oftentimes the shift from acute to chronic, one way of going through that experience is, we've done everything we can do, now it's up to you, and anything left, for you to deal with is likely all in your head. And what a damning way to make that transition, and what a burden for people to carry as they move forward. So being able to talk about that and normalize the complexity of the transition is a very important skill. And I know I hear myself talk, and I know it sounds quite, maybe it sounds quite deep, but even picking our spots to be able to say and normalize, I just want to normalize for you, to our client, that this is really complicated and challenging transition. And, I want to make space for that as we do what it is that we need to do on the return to work process. Because if you think about it, essentially we're encouraging clients or patients to become okay and choose to be willing to live with this unwanted circumstance. And, being aware that they are carrying significant uncertainty. So I think I covered this already, right? The idea of having language for the transition. And so I guess the other piece is that if you talk about the impact of that transition, to be able to name for our clients or patients, there's been a loss, right? A loss of who you knew yourself to be. And so it's normal to have a response to that loss, typically grief or sad feelings or anxiety or distress. Again, normalizing that and then being able to use that as a transition to say, so where I'm coming from with some of these skills that I'm offering you is to help deal with that component of your experience. And the people have done it before. So there is a concept in the literature called acceptance. And I guess I just want to speak to the idea of the term. Typically, what I've found anyway is that clients have a reaction to the word acceptance, and they often can hear, well, I'm not going to accept this because I'm not ready to give up. And so understanding the idea of acceptance is one thing, using the language of acceptance is another. And you've heard me name, throughout the last 40 minutes, this idea of resistance. When we encounter resistance, we also, if you're to put yourself in the client's shoes, likely resisting an unwanted situation. So instead of resistance, and again, if you go back into this both and thinking, willingness can be a useful term. And why I say both and thinking is asking people to be willing to, learn to be willing to deal with their pain right now, on one hand. On the other hand, don't give up for what it is that you want in the future. If you think about the opposite of willingness or the opposite of acceptance, resistance might fit. And again, talking about what's the impact of holding resistance. And if this even seems too technical, sometimes I just ask people, how do you feel about your pain, if you're really honest? They'll be shy, and well, of course I don't like it. I wonder if you hate it. I totally hate it. Well, I don't totally hate it. Some people say, but I'm frustrated with it. And what's the impact of you having that hate or frustration or resistance? And clients can usually name, it cost me a lot. And so what's the fear of, trying to give up some of that hate? Well, you don't ask me to love my pain. Well, no, not asking that, right? But if it's true that we have a certain amount of emotional energy to put towards life, and we're holding a lot of it with resistance or hate, might it be that that's preventing us from, then moving forward, right? Or having the energy to try some of this other stuff that's in front of us around learning new skills and returning to work. So both and thinking, and the idea of willingness. And if you look up willingness, there's some nice, I forgot to put that one on the reference list, but I have a nice description of what willingness might look like when it comes to dealing with pain. But again, willingness and acceptance is not about giving up. It's about telling the truth about how things are today, and willing to deal with pain as well as you can today, on one hand, on the other hand, holding out hope for the future. So just to reorient us again, because I know I'm pushing several threads at the same time in this talk, in many ways we get to play the role of guide in whatever our piece of the return to work process is. So being aware of recovery expectations and having the skills to elicit those, but also to tell the truth. Hey, for you to be clear on what expectations are going on here about your return to work, here's what you need to know. You've got 6 weeks. We have this amount of sessions. These are the targets that we likely need to get to. How can we shape the process of getting there together? To be able to speak to the transition from acute to chronic, right? And really the transition from medical system to return to work, right? Or from rehab to return to work. And our goal is to help as well to build self-efficacy. Essentially, we want our clients to be, to develop confidence that they can do it. So I think I will skip this. No, I won't. Right? Self-management stands in the gap, right, between waiting for others to do for me and taking responsibility as much as I can for managing the process. So I wrote just a little provocative, the third bullet there. See if you can partner with your client, even to engage in a relaxation strategy together. Doing this before discussions could be quite helpful. So for some of you, you probably do that already. You could teach me how to do it. For others of you, it might be a bit uncomfortable and something to think about. We're at 44 minutes and 30 seconds, but I do want to tell you about another potentially helpful technique, and I got this out of motivational interviewing as well, and that is simply taking the time to assess importance to the client and their confidence. So developing questions and scaling responses on how important is this return to work process for you, scale of 1 to 10. How confident do you feel to complete the process, scale of 1 to 10? And then asking the questions of what might help, what could we do to move a response even 1 point higher on the scale. And if you just sort of take your creativity, you may need to shape the questions that fit your circumstance, but sometimes even that is a great entry point to be able to say, okay, so if we do this, it'll move at 1 point, and why don't we revisit it in a day or a week or something like that? And it's a way to measure, but also for us not to proceed assuming that the client feels good about what they're doing. And I mentioned self-efficacy, or this idea of developing confidence. And I guess all I want to say for this slide is, if you notice that you hear a lot of can't do talk, being able to identify that with our clients. I noticed that you make a lot of statements around can't do, and that's okay and it makes sense, right? And that is often about the sadness or the loss of things that we used to be able to do, but then looking for exceptions to, think about that. You've likely heard this, I don't think I can do it, or I don't think I can do anything. And inviting our people into this process of, can we begin to build a can-do list that symbolically identifies the fact that you can do something, and we need to start somewhere to build the positive side of this ledger. We don't need to destroy the can't-do list. That's often about grieving or not seeing alternatives, but to begin to build a can-do list can develop some confidence and help clients see a bigger picture of the fact that they have lost some abilities, but not all abilities. So it's important to support self-efficacy as much as we can, ensure solutions are client-generated, give as much knowledge and understanding of that whole adjustment process. Again, that really speaks to, hopefully, what's coming across today in this discussion. Here's some examples of supporting self-efficacy. Normalize it. It can be awful, but it is doable. People have done it before. Just let you read those. There is a preparation phase in working with our folks. That's a summary slide. Normalizing loss, grief, adjustment, teaching pain versus damage, return to work as part of the healing process, making sure that they know all the different expectations they're going to encounter. And then we move into action. Practice, right? Like I said, could you practice a relaxation strategy together at work or at your clinic? Even on the phone, doing rehab specialists or case management. So arrived at the end of the talk. Appreciate your willingness to hear me out, and those of you who took a risk and tried some of these skills or these practices. Empathy and relational competency, some of the skills that we talked about, they really do make a difference as far as disarming our folks, getting them to develop into a trust relationship, and can help with their stick-with-itness. Really important to be able to normalize the complexity and to identify the transition tasks as people move from acute to chronic, from rehab to return to work. Be aware of and monitor resistance. It's not a bad idea to be able to speak to resistance. I didn't go into the mother-in-law metaphor, but when you go back over these slides, look at that one and think about, most people have an experience of learning to deal with or tolerate someone in their life that they wouldn't choose, typically because it's family. And that is a great metaphor for pain. And clients, in my experience anyway, they seem to really get that, right? I tolerate my mother-in-law, I tolerate my pain, I don't love it, but if I hate it, it doesn't work. I'm the one who suffers. Expect setbacks. And the last thing I want to say is that I have a dear colleague down the hallway who regularly says, so what would it be like if you were in the middle of this person's process? And that's quite sobering to think about how really would I respond. So I want to encourage all of us. This is challenging but very rewarding work. It's important work to be done. And that's where I would like to end. Thank you very much.
Great. Thank you very much, Matt. I think that we do have a couple of questions. Lisa, do you want to take those on?
Sure. There's a question from Salvina asking, how early in the process should we intercept to ensure the acute does not become chronic? Is it before usual healing time or as early as when the actual injury or illness occurs?
The response would definitely be nuanced. I would say that if you are going to start out on this process, I'm thinking about Eric, a physiotherapist who works next to some of the psychoeducational piece early on, if he can see that a person's anxiety response is out of keeping with the injury, or if what they verbalize around, worst case scenario comes up quite consistently, even in the physiotherapy treatments. His experience is that you're not going to lick this in one intervention, but just gently educating and even moving towards stress reduction techniques can be a great thing to do. And oftentimes, I'm not saying it's hard and fast, but oftentimes this stuff wasn't even on the radar till at least 3 months. And in my opinion, doing it sooner could make a difference.
Okay, Megan has a question. She says, I've been told that people actually go through the 5 stages of grief, the Elizabeth Kubler-Ross book on death and dying, when living with chronic pain or injury that is affecting their life, like surgery with long recovery or paralysis. Would you agree that they grieve the person they were pre-injury?
It's complicated, isn't it? Because they still are there. And so in my experience, sometimes this is about grieving specific losses or aspects of role, but at the same time needing to do the tasks of reclaiming, core essence of who one is. So I'm not so sure about, what I tell clients is that with grief, it's important to acknowledge and to make space for it. And it's in my opinion, it seems to be more chaotic than just going through the different stages. Likely for many clients, they need to go through all the different stages at one point, but just not losing sight of the fact that it's not a complete destruction of one's person, and that often the key elements of who they are in relationships, their value system, what they stand for. We do a class in our clinic. We've changed the name. I can't remember what it's changed to, but it used to be called Old Me, New Me. And what we do is sort of track what were you about and what was your value system. And then post-injury, how has that been impacted? And then, what needs to be grieved and what do you want to stand for and your life to be about going forward? And it's a great way, do it on the board, it's a great way to capture the grief parts and the reclaiming of self to move forward. So yes and no, but it's both and.
Lisa, are you there? Do we have...
I think that's it. There's another one. If this person had trouble getting back to surgery, and has since has had trouble getting back to work, and has since had surgery, which increased CRPS pain levels in all areas of the body, how would you approach something like that with rehab?
So essentially, they not only did the medical interventions not work, but it made a person worse. I mean, I think it's really normalizing the emotional, psychological impact of that, you know. And again, but it's that. Let's go back to the both and thing that I've been saying, telling the truth about the pain right now, right, and honoring it, and on the other hand, realizing that if we stay in that place of telling the truth, it'll prevent us from moving forward. So, but if you don't tell the truth about the pain or the trouble first, you know, we will end up pulling people along, or they'll make change at a level that likely won't be sustainable, or that they'll need to circle back around and do that, you know, do the grief work or do the emotional processing around getting your hopes up and then having them dashed by failed surgery.
I think that's all the questions we have on here at the moment.
Great.
All right, great. Thank you very much. I think that's everything. So what I will do is I think I will close down. Thank you everyone for joining us today, and thank you very much to Dr. Graham for his presentation. That was wonderful.
Great, thank you.